I'm very glad to be here today to tell you about a project that I think is interesting. Hopefully, you will by the end of the talk, that I got involved in when I became a part-time consultant at the state of Wisconsin Department of Health Services after my retirement from VA and UW. The real title of the talk should be what's the subtitle on that first slide: Wisconsin's integration of hub and spoke with health home models for people with substance use disorder. Even more, it should say Wisconsin's implementation pilot of integrating hub and spoke and health home models, because this talk is actually about the ups and downs, peaks and valleys of implementation. While I was in VA leadership roles, I often worked on implementation projects that were sometimes nationwide and wrote some papers about issues in implementation, and it seemed complicated then. But I had no idea really how simple the VA system was compared to the complexity of trying to implement a new program in a non-VA US healthcare setting, and in Wisconsin in particular. And we'll talk a little bit about why that is the case. So this is also, you should know, is the story of an implementation of this integrated model that is in progress right now. I have to come back in about a year and a half to 2 years to tell you about all of the outcome measures and did it work. But I think it'll be of some interest even at this point. Well, we mentioned two models on that slide, the hub and spoke and the health home model. And the hub and spoke model was made famous in Vermont in the mid 2000 teens. It made famous in Vermont. It was quite well known when we started this project, and it was known mostly as a mechanism to get more people access to medication assisted treatment faster as the opioid epidemic swept through Vermont. It was going to do that by connecting experts at hubs with primary care and other more generalized providers at spokes, and that together the expertise and the expanded access would help more people with opioid use disorder get better sooner. The health home model has been used across the country by both primary care and more specialized services, and when in Wisconsin most prominently in dealing with people who have HIV infections. You can see two names on the slide, and there's only one of me talking. I had been hired in hopes that I'd be helpful in helping create systems that would help MAT expand faster into more and more parts of Wisconsin. And the other person listed here is Vaughn Brandt, from a behavioral health policy specialist from the Medicaid service. And he has had extensive experience in models that expand and patch the holes in the support systems that are supposed to help people with mental health and substance use disorders. Another 2 points about this title slide. First, much as I found at VA, the bureaucracy of the state of Wisconsin has some remarkable people toiling away inside those big buildings around town. Vaughn, for example, is a tireless worker, creative and empathic thinker who never says a negative word as he's battling not only a difficult clinical entity, but also the complexities of governmental agencies. If this model works, it will be mostly due to his work, and he'll probably never get any credit for it. Second, the reason I'm using these slides, which with the title that's not exactly correct, is it's a lot easier to actually talk with slides that aren't actually right, and rather than getting all the slides ready more than a month in advance so that they can go through the state approval process. So there are the pros and cons of work in the bowels of bureaucracy. But overall in this talk, I'll try to talk about how government functions, about human needs, about funding mechanisms, and about medical knowledge and how all those things interact in trying to implement a new treatment system in Wisconsin. So This slide is one of those that's put forward with typical governmental understatement. I should point out the understatement happens on the slides of bureaucrats, not the slides of politicians. This new model, as I said, is the integration of hub and spoke and health home model, designed to create better treatment for people with substance use disorders and other co-occurring conditions. As I said, when hub and spoke was first discussed around the country, it was discussed as a way to get primary care physicians to extend the number of providers prescribing buprenorphine from their office spokes, and that they'd be more apt to do that if they were connected to the support of addiction specialists at associated hubs. So, next part of this talk, we're going to come along periodically to papers that will be listed in the relevant readings and the slides at the end of this talk. You can write in for or contact Heather for copies of the slides as you want. But I wanted to point out that MAT is increasingly noted to be remarkably effective, and therefore we'd want to spread it out, right? My favorite two articles on the effectiveness of MAT are ones that address the two certainties in life, taxes and death. So Fairley et al. In July of 2021 was the first author of an article in JAMA Psychiatry by a team of researchers from the Palo Alto VA and Stanford that actually used to report to me when I was in the Washington, D.C. for the VA. They showed that methadone and/or buprenorphine care were cost-effective for people with opioid use disorder, and that each of those interventions was enhanced by overdose education and naloxone prescription plus contingency management. Adding individual psychotherapy actually increased the cost beyond that thought of it's cost-effective unless it cost less than $42 a week. But those effectiveness estimates were initially made without including Department of Corrections expenses. When you include Department of Correction expenses in, those two MAT interventions actually became cost savings. This is nearly unheard of in American medicine, where the savings related to a treatment make the treatment actually cost saving. These interventions actually make money. So they would save the taxpayer if you could actually figure it out. So that's the taxes one. Watts et al. In this month's American Journal of Psychiatry showed that treatment with medications for opioid use disorder, especially buprenorphine and then methadone, resulted in decreased suicidal mortality and overall mortality, with naltrexone showing a decrease in overall mortality, but not suicide mortality. So much less death, it's cheaper, what's not to like? Well, the problem is that the most common outcome of MOUD treatment is that people stop them. Despite the fact that it's remarkably effective, and we could give talks with many more papers documenting the effectiveness, people don't usually stay on them. Even more sad is when you look at people who die of opioid overdoses, most of them have never had a trial on MOUD. So the issue then, and if you think about this, this isn't uncommon for American healthcare. You know, most people don't follow their diet. They don't follow their exercise program. They don't follow many things that would make their quality of life and their length of life better. And the folks with struggling with MOUD also don't do that over years and years. They may do it for weeks and months, but not years and years. And the problem is the mortality is still there, often years and years out. So we need to create a model that might help people get to the drug and other treatment, start the drug and stay on the drug, or get to the treatment, start the treatment, stay on the treatment. what can we do to improve engagement and treatment retention? Could it be that the health home model, which is very supportive of ongoing interaction with care, could that supplement the hub and spoke and lead to more people remaining in opioid use disorder treatment longer? Well, that's the theory. That's what we're hoping for. A little history. So the origins of this project probably are easiest to trace to 2017. By then, Wisconsin, led by John Nygren, a conservative legislator from northeastern Wisconsin, who'd been galvanized by his family's struggle with opioid addiction, had done some good work in attempting to control overprescription of opioid pain relievers. Remember the good old days when we thought this was all a pain reliever problem? That Wisconsin also done a good job of training and getting waivers for prescribers of buprenorphine products, and in supporting projects like the Hope clinics that serve underserved areas across northern Wisconsin. But by 2017, it was also apparent that heroin was moving in, deaths weren't going down, and fentanyl was just on the horizon, mostly in other parts of the country. An April 2021 issue of the CDC's Morbidity and Mortality Weekly Report was looking back at this time period. Actually, that report looked at 2018, showed that at that point in time, more than 2 million Americans met criteria for OUD. Just over 47,000 had died that year from ODs, and costs were just over $1 trillion for those who died and those who were cared for. Wisconsin had 36,000 opioid addicts, just under 1,000 opioid overdose deaths, and combined costs of $18.7 billion. In other words, a per capita cost of about $3,200 for every citizen in Wisconsin. Of course, some of those numbers look low now. While the total number with OUD isn't too much different, the OUD-related deaths are markedly higher. But in 2017, things were bad enough to say, we need to study this. And the governor's task force on opioid abuse asked the governor to order a Pew Foundation system review of Wisconsin's substance use disorder treatment system. And about a year and a half later, the Pew Foundation came up with, you should create a new treatment model based on Vermont's hub and spoke approach in order to enhance access to MAT services. So the hub and spoke model is well described in an article on the reading list entitled Vermont Hub and Spoke Model of Care for Opioid Use Disorder Development, Implementation, and Impact by John Brooklyn and Stacy Simon in an NIH publication. It described the lack of availability of buprenorphine or methadone throughout most of Vermont as the OUD epidemic swept through. They decided to divide the state into 5 regions that would each be served by a hub clinic that had expertise in substance use disorder and especially opioid use disorder, and was co-localized with a OTP that could supply methadone as well as other MAT services. A prospective patient could enter this system of care via evaluation at a hub in their region or via a hospital ward or emergency department, a residential addiction program, Department of Correction facilities, or community mental health programs. Hubs were responsible for initial development of treatment plans, and patients could be transferred to primary care run spokes or from those spokes to hubs, this was clinically appropriate. But one thing the model presupposed is that it was critical to move sufficient numbers of people with opioid use disorder to spokes to maximize efficiency and make access easier for people with opioid use disorders. Funding for this hub and spoke project in Vermont came from the Affordable Care Act Health Homes Allowance, and outcome measures were standardized and required. And at the time of the Pew review of Wisconsin system, this was truly the state of the art. So The next step was to get it into the biennial budget. And the biennial budget included an allocation for a pilot project for a substance use hub and spoke treatment model to be delivered under the Medicaid health home benefit for persons with substance use disorders. A state plan amendment was submitted and approved by the Center of Medicaid Services for Wisconsin to provide this new benefit. And it's important to understand that actually when we went into the 2019 to 2021 budget period, Wisconsin didn't have a lot of money laying around. And part of why they had to go through the health home benefit, and in that it made a lot of sense, is when you do a pilot for a new benefit, the federal budget picks up 90% of the cost, and the state budget picks up 10% of the cost. And the pilot can run about 2.5 years. So states can try out new approaches without taking a risk that would put their Medicaid program underwater. And when I first heard this, I thought, geez, Wisconsin doesn't really have much skin in the game. But it's still a big number for a state. And the other thing I learned from talking to people in Medicaid is that once you put out a benefit, it is very, very difficult to pull it back. So let me see if I can turn on that. And so when given the Pew recommendations, as I said, we decided on 3 sites, but it became interesting to start looking at the differences between Wisconsin and Vermont. Vermont is really a pretty unusual state. It has no areas of population that are considered densely populated. Its most densely populated county is 13 times less densely populated than Milwaukee County. There is nothing like Milwaukee's near north side. The most densely populated county is less densely populated than Dane County. Vermont's a very homogeneous place in terms of race and ethnicity. While Wisconsin isn't terribly diverse overall, there are certain pockets of Wisconsin populated by significantly dense populations of ethnic racial groups that have been systematically disadvantaged for many generations, and where there are severe problems with housing, employment, and legal issues. This turns out to be quite important in terms of creating a positive response to treatment for opioid use disorder. Again, on our reading list, in the American Journal of Public Health in 2022, Pro et al. Analyzed client-based and state-level variables as they are related to outcomes of opioid use disorder treatment. It turned out that the Distressed Communities Index, in which a single metric accounts for community levels of low education, housing vacancy, adults not working, poverty, income, changes in employment, and changes in number of businesses, was a stronger predictor of treatment outcome for clients that came from one of those distressed areas in a state than any client-based variable. So in other words, the client's number of comorbidities wasn't as strong as what kind of community did the client come from in predicting outcome for OUD. Now, Wisconsin has 8.2% of the zip codes falling in the distressed range versus 2% in Vermont. What's even more amazing is, places like Kentucky, Ohio have have 30 to 40% of their zip codes in the distressed area. So while you could think, geez, maybe what we should do is try to make communities better, the other way the health home model might work is if a person has a recovery coach or peer support person working together with the care coordinator on their recovery, maybe having an experienced guide to recovery can help you work through the risks and dangers of that community as you're pursuing recovery. Third difference between Vermont and Wisconsin. Vermont has a very strongly centralized governmental system at the state level. At the start of their hub and spoke model, 86% of their entire population were already enrolled in a primary care medical home as defined by NCQA. So it was, in the state had already divided into 5 medical regions. So adding MAT teams and substance use disorder experts to those medical care homes created hubs and spokes almost automatically. In contrast, Wisconsin has a system of government often referred to as home rule. The State Department of Health Services, I've discovered, can cajole, entice, educate, incentivize county and city level health authorities and in private health agencies, but cannot order them to organize their healthcare according to a state rule unless a full and formal law and regulation is passed, which is a really heavy lift. And really, county boards can tell people at the state level, we're not interested in doing that in this county, and don't have to give another reason why. Or the county sheriff who runs the jail says, I'm not interested in providing SUD services in this jail. They have a strong influence. So getting to that rather pretty model that Vermont had is a much heavier lift in Wisconsin than there. The one thing that I learned in conversation with people in the leadership of the hub and spoke model in Vermont during the time we were developing our model is that they found they could not transfer as many people to spokes as they thought they'd be able to. Indeed, people with substance use disorder issues proved to have, guess what, complex and severe problems. And more of them stayed at the hub for their expert specialized treatment than had been planned. So there was some reason to believe that things might not be so simple in Wisconsin. And we'll see here. My slides are stuck, Matt, if you're there. Oh, there we go. So we already, so we talked about hub and spoke. What about Medicaid Health Home? So Medicaid Health Home coordinates care for Medicaid members with chronic conditions. It will be coordinated for primary, acute, behavioral health, and long-term services related to the member's chronic conditions. Health homes often target specific geographic regions rather than statewide care. There are places that have substance use disorder health homes. Some states have used Medicaid health home benefit to create substance use disorder health homes. Again, those health homes serve individuals whose addiction challenges are complex, chronic, or present significant health risks. And then hub and spoke coordination. Hubs are supposed to provide regionally specialized addiction treatment and evaluation to address complex needs. Hubs support locally based spokes via consultation and training to care for less complex patients. Together, hubs and spokes are intended to expand the capacity of quality care for addiction. One of the things that was important in setting up health homes or this program in Wisconsin is the clear direction that we were not, as Vermont started out, interested in a opiates-only treatment program. In Wisconsin, there were probably about as many counties who were reporting that methamphetamine was their number one problem, or even the old tried and true alcohol was their number one problem, as were reporting opioids in the mid-teens. and certainly methamphetamine continues to be a major problem. Um, and we didn't want to be specialized to only opioids, although obviously opioids are a critical part of the death by overdose problem. So what did we want to come up with in our integrated recovery support service program? We wanted to harness the expertise of specialty addiction programs and build the capacity of the local local primary care providers to increase access to quality care. We wanted to provide specialized care for individuals with a variety of addiction challenges. Who are we going to treat? Medicaid eligible youth and adults, usually youth of 16 and over, who have substance use disorders and are experiencing or at high risk for experiencing chronic associated physical and behavioral health conditions. Now, if you think about that, that's a wide range of people. Now, the good news, we really aimed this more intense program at people with a moderate to severe substance use disorder, but we didn't want to limit it to only people with the most severe substance use disorder, because you're likely to miss a signal of efficacy or effectiveness in populations that aren't at the most severe level. And we didn't want to miss that. So we want to get somewhat of a range of people into this project so we can see how people with different severities of illness and different complexities of illness do in the model. One way of talking about what we're providing is whole person integrated care. Substance use disorder health homes serve people with addiction issues, but team-based care should also address, quote, whole person needs such as HIV, TB, hepatitis screening and treatment, chronic comorbid conditions, smoking cessation, obesity reduction. And then the bottom three here, which are really quite understated. They need help with family relations and re-engagement in the family. They need to meet personal recovery goals, which might be spiritual, interpersonal, intrapersonal. And they need to integrate back into their community, into their roles in the community. They need a job role. They need to have housing that's safe and affordable in the community. And they need to address any kinds of legal concerns that have arisen during their time of dealing with their addiction. So actually, beginning in July of 2021, we started our pilot. And that was the month in which the first patient was brought into the program in Milwaukee County. And there are 3 locations. We'll talk about the 3 locations in a bit with substance use, who are treating people with substance use disorders and co-occurring needs. I suppose maybe actually so we selected the 3 locations in a process that took probably a year, and it's an interesting thing again at a state level in a state like Wisconsin, where we need to attract interest from counties and agencies around the state. So we had to put together a team to put together a request for proposals, essentially, for sites that were willing to put together a program that had both hub and spoke and health home model characteristics. Creating the request probably took 3 months. Responding to the request probably took 4 months. And then evaluating the responses and talking to people at the various sites about some of the specifics of certain certain responses, took another couple of months. And in the end, it took about a year to figure out 3 pilot sites that had both evidence of high quality work, but also served populations that were of particular interest to Medicaid, to state government, and to hopefully the citizens of Wisconsin. And so we ended up with a site in rural northern Wisconsin, a tribal nation site, and a site in inner city Milwaukee. It'd be wonderful if there would have been enough money set aside in this project to gather some more sites. But we ended up with 3 sites. Luckily, they were all 3 that were scored high, very high in the among the 17 sites that submitted proposals. So hubs and spokes will serve people who come to them via a wide range of referral sources, much like I listed off for the Vermont model. The hub provider staff meets people both inside and outside the clinic walls. It can be a mobile community-based service, or they can come to spoke sites to support follow-up and coordinated service delivery. Hub services are offered at various variable levels of service intensity to support individuals with significant needs through their recovery. There are a fair number of people who come into treatment quite unsure about it, and pushing too much on them on day one leads them to run away from treatment. Intense treatment that is very short also is not as effective as treatment that happens at lower intensity over a number of months and years. So we want both hubs and spokes to work together to match service intensity to the individual's needs as they perceive them. Now, hopefully, if you perceive a lot more need than the individual does, you might be able to, as a clinician, move them towards working on those needs more quickly, but you should not push them off if they're deciding to progress a little slower than you'd like them to. It's their recovery. That's a critical part of our health home integration with the hub. The hub, though, does emphasize rapid engagement. You need to get people in. If somebody hits the ER, they need to know they can be at your hub site in, the next morning at latest, and that they might be visited by one of your recovery coaches in the ER who would help them get to the hub site the next morning. In other words, you need rapid engagement, and you need retention. One of the ways we devise the benefit is that hubs and hub and spokes would still get a payment if a person was only coming for one unit of care per month. Okay, and that could be 15 minutes. If they were still maintaining some kind of connection, they still got paid, and they're highly encouraged to not take people off their roles if they still can make some outreach to family, friends, others who might get that person to get back into care. And then hub services transfer primary care collaboration to or from a spoke when indicated by the patient's assessed level of care and patient choice. Who works at the hub? Usually a program director, a multidisciplinary assessment team, an addiction psychiatrist or psychologist, nursing services, SUD counselors, WAVE MAT providers, methadone dispensing providers, and most critically, really for the health home part of the hub staffing, care coordinators and certified peer specialists and recovery coaches. Notice we put those in bold because they're so critical for the focus on engagement and retention. Remember, all those other people who are on the list tend to give specialized care, but most people quit specialized care. We're hoping that care coordination and peer specialists and recovery coaches work together with that expert staffing and with the more general level spoke staffing to maintain retention over time, which is much more likely to lead to stable recovery. Spoke services monitor adherence to treatment and coordinate access to counseling, recovery supports, local resources. They integrate management of the patient's MAT into general medical care and their addiction care into general medical care. And for the opioid use disorder, it includes professionals waived to prescribe buprenorphine. Now, we've talked about health home a lot. What are we actually paying for health home services? Includes comprehensive care management. Somebody at the hub is going to be tracking the hundreds and hundreds of people at the Milwaukee site and the 100 to 200 people at our other sites, probably, over time. It's the responsibility of the hub and spoke together to know, is that person fading away from treatment? Do they need to be reached out to? How are we keeping this person in the best and most comprehensive amount of care that they will tolerate and benefit from? Care coordination. This is a skill of how do you actually put together a plan for a person's week or month that that person can actually follow. Okay. All too often we put together tangled referral patterns for all kinds of support for these people with complicated care. And of course, they can't get to all of them. And they're like, why weren't you at this clinic? Why weren't you at that clinic? Why weren't you at that meeting? And it induces a sense of failure. And so care coordination is quite critical. Health promotion, what are you doing for health in general? One of the things I found over my career with a lot of alcoholic people with alcohol problems is that men tended to come in for treatment in their mid-40s, and they'd been drinking heavily since 20, if not earlier. And they'd just be shocked at how much their back hurt and how how could their cholesterol be that high, and et cetera, et cetera, et cetera. Have a medical list, 10 diagnoses long. And what you'd find was that, of course, they hadn't seen their doctor in 10 to 15 years, except for runs through the ER when they were in withdrawal or the like. And getting back into some kind of program pursuing health was a not only critical part of achieving a better life, but to some degree, a place where the person could feel cared for and cared for by their health team because, hey, we're interested in your back feeling better, whether you had a drink today or not. Transitional care and follow-up. How do you keep people in a program when maybe they only need a little bit of care at this point in time? They're either plateaued and they don't want to aggressively pursue things right now, or they're doing really, really well and they just want to keep in touch. How do you make those transitions? And then how do you transition from spoke to hub and back and forth as appropriate, or residential to hub and back and forth? Patient and family support. We've realized already in our program that we needed to emphasize that more and actually pay more for interactions that happen only with family or people who are close enough to the patient that they're calling them family. And then finally, it says referral to community and social supports. We're pretty clear that just referring is very unlikely to work well. This is one of the places where the recovery coaches and care coordinators can help a lot. Personal introductions to the community or social support agency. Falling together to get that first appointment and maybe talk to the person. Maybe walking in with your recovery coach. So when you go into that waiting room and find out that the person's running 20 minutes behind, you don't bail, but you stay and you get connected. Now, one of the things that's important to understand is that while we are paying new money for health home services, people are still going to be able to collect billings for the medical services they usually already have been billing for. So this is an add-on benefit. Now, this actually is an interesting one because it turns out that when you have health home services, all these billable services that happen, especially in outpatient settings, become more profitable because you have fewer people missing their appointments, and you have fewer people showing up in your office with emergencies sort of unannounced that kind of destroy the day in the clinic. So a lot of clinicians are who are still providing their normal billed services with appointments are very, very happy to be connected with the health home services. The other thing that we've realized is that we are now paying for the health home services with a per member per month stipend. And we've already raised this from having 3 different levels of payment to 5 different levels of payment to try to match payment better to intensity without making the bookkeeping more expensive than the care. This slide just highlights the idea that you can be referred in an urgent or a non-urgent way. You go to the health home where you can spend time in either hub or spoke. One thing we're emphasizing a lot is using telehealth. And telehealth, in this case, works not only clinic to clinic and staff to patient, but really makes consultation by the expert at the hub to the more generalist person at the spoke work better. It makes an expert counselor in a specific kind of treatment available to somebody who can come to the spoke or even get that care at home. We're doing everything we can with telehealth to maximize not only the comprehensiveness of care, but the convenience of care. Because when you're taking on care that's going to last ideally years and years, although at lighter and heavier amounts over time, you need to make it as the least burdensome it can be, or it just gets overwhelming. So what are our 3 pilot sites? We have the Family Health Center, which is a FQHC related to the Marshfield Clinic, but they're actually running their hub out of the Family Health Center in Minocqua, which has an adult alcohol and drug recovery center. And they're operating over 5 counties, Forest, Iron, Oneida, Price, and Vilas, as well as in both the Forest County Potawatomi community, as well as the Lac du Flambeau Band of Lake Superior Chippewas and the Sokaugon Chippewa community. So 3 different tribal nations in over 5 counties, and they are our most rural site. Luckily, they're used to working in rural sites and have a lot of both special insights and creative insights as to how things can work in the rural areas and the special communities they serve. We have a site in the Brown County area, which is the Oneida Nation Behavioral Health Center, again, a FQHC, which will provide services to any federally enrolled Native American who is in the Oneida Nation or in Brown and Outagamie counties. And finally, we have, now those 2 sites are both sort of traditional medical care providers and behavioral health care providers who are adding on this new entity. Wisconsin Community Services is a bigger and more interesting reach. Wisconsin WCS, which is how we refer to them, is a nonprofit community-based, really social service organization, which is providing services in the most densely populated parts of Milwaukee County. It actually, Milwaukee, well, the problem in Minocqua is that qualified health care is scattered across many, many miles. There is actually a lot of healthcare services in Milwaukee. It's just such a complicated system that people who are stressed beyond belief by not only their addiction problem, their comorbid mental health problem, but also their economic, housing, and legal problems and family problems. When you're in that state, trying to navigate the issues of getting care for this complicated disorder in Milwaukee is remarkably difficult. Milwaukee, as I told you, scores very, very high in the Distress Community Index. Some of the zip codes in downtown Milwaukee are scoring 96 on a 100-point scale of distress. And while it'd be great if the community could be, quote, cured, we're going to settle right this point for care coordinators and recovery coaches who can link services and not only provide a map through that complicated set of services, but also hopefully provide a guide who will often take people personally to each of the sites. So we're going to evaluate these folks using a variety of scales. We're going to look at their socio-demographic situation, their member complexity scale, which is a scale we made up for this program. We're going to use a monthly version of the Brief Addiction Monitor. I highly recommend using Brief Addiction Monitor in your care. And we're going to look at the frequency and types of treatment and services provided by the professional and paraprofessional staff. I'll let you please do a search on Brief Addiction Monitor and look at this 17-question measure. That's a self-report instrument. It's endorsed by the APA as an evidence-based evaluation program, and it's on the Cerner and EPIC EHR programs at this point. I think it's something that would help your care of people with addictions because it looks at use, at risky behaviors, and protective behaviors, and has software which allows those outcomes to be graphed and to be used in creating and updating treatment plans. I think it's a great boon to anybody's work with this population. And finally, we'll have a UW independent program evaluation looking at the things that are listed there. For additional information, you can consult these web pages or Vaughn or me, and the relevant readings were listed at the end. With that, I will say thank you. And we have just a couple minutes left for questions, if there are any, and I haven't lost the whole audience by this point. So thank you very much. And hopefully I'll be back in a year and a half or two to tell you how this turned out. Or it'll be such a stunning success, you'll have already heard about it.
All over the news.
That's right, yeah. Thank you.
Thank you, Dean. I think Randy had to get off, but thanks so much. This is interesting to hear about future projects. Any questions from anybody in the audience?
Yeah, Dean, this is Mike. Are you stuck with these 3 pilots, or during the course of the next couple of years, will you be able to add something like Eau Claire or La Crosse or Madison?
Yes, well, we're actually, that's exactly the kind of places we're thinking about. Is with 3, you kind of end up with the kinds of sites we have considered the most special populations. But the most frequent population in Wisconsin is people who live in sort of medium-sized towns or cities, or smaller towns and cities like Eau Claire, La Crosse, et cetera. And they're served by different kinds of healthcare delivery systems. And yes, we should be able to add, assuming things are going well, we're hoping we'd be able to add over time. So it certainly does happen in this kind of funding arrangement that happens. So we're hoping to be able to do that. Thanks, Mike.
This is Allison Miller. I'm at UW Health, and I don't know if you know, have a small hub and spoke pilot project that has been going on for a little bit over a year.
Yep.
And it is game changing for us. I know there's a few people on the phone right now, or we're listening to this, who are part of this, and having support with a nurse navigator and peer support on site and to support these patients. It's tremendous. And we recently have been working with our health information team within HealthLink to kind of determine, how many touches is this, cost efficient, and where are we going with this? And engagement is really high. We have shown significant decrease in ER visits as well as hospitalizations. So just in doing this small project in a year, you really can save a healthcare organization a lot of money.
Yeah, it's when you look at it, the healthcare organization can save money, but society as a whole saves even more money. It's really fantastic. The problem is the people who have to spend the money on the front end. Like one thing that would lower dramatically over time, if you do this well, is Department of Correction funding, right? But you can't free up the Department of Correction funding to pay for the new program very easily. You can't, so the question is, how do you do this to flip that funding formula for state services at the front end and get it going faster? But I'm so happy that you chimed in and talked about the increased engagement and the decrease of emergency services. It's just exactly what we'd hoped for. I'm so glad you guys are doing that. And we maybe should talk more, especially if we go to another set of sites, because your experience will probably inform certain sites better than the 3 sites we have going, which will inform other kinds of sites. So thank you.